Aim of this talk is how to integrate the use of bone scan in the clinical workout of cardiac amyloidosis. To clinical cardiologists and cardiac imagers, the expression of left ventricular hypertrophy describes a specific phenotype of increased wall thickness and all left ventricular mass. However, the hypertrophic phenotype is a common final pathway of multiple different genetic and acquired conditions, including abnormal conditions, sarcomeric abnormalities like, for example, hyperplasia, hypertrophy and disarray, and intracellular and interstitial accumulation of different materials like fibrosis, infiltration, and so on. So it's very important to understand and to evaluate at the beginning the different kind of diagnosis, the possible different kind of diagnosis in order to treat at the beginning the patient in a different way. In 2015, for the first time, the use of nuclear cardiology was well described in this position paper of the European Association of the Cardiovascular Imaging for the detection of cardiac amyloidosis, in particular for the detection of ATTR cardiac amyloidosis. Also, the other techniques and non-invasive techniques are well described and useful for the evaluation of this type of disease. In 2022, this algorithm was a little bit updated, and the working group of myocardial and pericardiac disease of the European Society of Cardiology published a new statement on the use of the different imaging modalities for the evaluation of cardiac amyloidosis. And as you can see here, also for echo and for the cardiac magnetic resonance, the different variables useful for the diagnosis of cardiac amyloidosis is changed and improved. For example, for echo, you can use also a multiparametric score for increase the sensitivity of detection of cardiac amyloidosis. But where nuclear cardiology is in this algorithm. So this is the very nice flow chart that you can use for the evaluation of your cardiac amyloidotic patient. And as you can see here, the use of bone scan for in this algorithm is very well established. And you can use for diagnosis and but up to now, not for the follow-up of the patient, so only for diagnosis. If we analyze in deep this algorithm, we can find 4 different type of 1, 2, 3, 4 scenario. Start for the first one. Scintigraphy does not show cardiac uptake and assessment for monoclonal proteins are negative. There is a very low probability of cardiac amyloidosis, and ATTR and AL amyloidosis are unlikely. An alternative diagnosis should be considered. Nevertheless, if suspicion persists, you should consider the use of CMR, followed by cardiac or extracardiac biopsy, as bone scintigraphy could be negative in some mutation ATTR disease. For example, tracer uptake depends on TTR fibril composition and in rare subtypes of cardiac amyloidosis. And you can find these red flags where nuclear scan is negative and this suspicion is very low, but at the end, clinical scenario can be more focused on amyloidosis, and you need to consider that even if your cardiac scan is negative, you can have different type of ATTR or AL amyloidosis. So you need to be considered to keep in mind that you have some red flags in this first scenario. The second scenario is when scintigraphy show cardiac uptake and assessment for monoclonal proteins are negative. If cardiac uptake is grade 2 or 3, ATTR cardiac amyloidosis can be diagnosed. proceed with genetic testing to differentiate between ATTR and ATTR-WT forms. In the case that cardiac uptake is grade 1, like this one, non-invasive diagnosis is not possible, and histological confirmation of amyloid deposit, could be, for example, extracardiac, is required. So in this scenario, this is the step that you should consider. But we have also a third scenario. So scintigraphy does not show cardiac uptake, and at least one of the monoclonal protein tests is abnormal. So AL amyloidosis has to be ruled out promptly, and CMR can be used to confirm cardiac involvement. If CMR findings do not support cardiac amyloidosis, the diagnosis is very unlikely. In the case that CMR findings are supportive or inconclusive, cardiac or extracardiac histological demonstration of amyloid deposit is required to diagnose AL cardiac amyloidosis. If CMR cannot be performed, consider performing biopsy directly. So this is the third scenario. And what about the fourth one? So scintigraphy shows cardiac uptake, and at least one of the monoclonal protein tests is abnormal. So ATTR amyloidosis with concomitant MGUS or any hematological disorder that produces FLC, AL amyloidosis or coexistence of both AL and ATTR amyloidosis are possible in this scenario. Diagnosis of cardiac amyloidosis in this case required histology with amyloid typing, generally with endomyocardial biopsy. So this is very, very well described scenarios, and you need to keep in mind the different kind of variables that you can have with your myocardial scintigraphy and with all the clinical information that you have. But at the end, nuclear scan is very important for the clinical purpose in this subset of patients. So finally, you can have false positive and false negative of bone scan that you need to keep in mind. And so you have different kind of situation and how to suspect and confirm false positive and false negative scan. So please keep in mind this slide, because it's very important for your clinical purpose and for your for the management of the patient in clinical routine. At the end, the ESC published a new statement also for the treatment of the patient. And so you can see here that the use of myocardial scintigraphy is necessary in the evaluation of this kind of patient, because treatment of this kind of patient is mandatory. And as if you start before as possible, the treatment is more efficient, and you can increase the outcome of your cardiac amyloidotic patient. Thank you very much for your attention.